A 6-year-old patient is diagnosed with moderate atopic dermatitis characterized by acute flares on the flexural areas. What is the best management strategy for this patient considering both pharmacological and non-pharmacological options? Explain the rationale behind your choices, referencing the underlying pathophysiology of atopic dermatitis. Answer: the management of moderate atopic dermatitis in children includes a combination of non-pharmacological and pharmacological approaches. Non-pharmacological strategies primarily focus on skin hydration and avoiding triggers. Patients should use emollients generously and frequently, especially after bathing, to restore the skin barrier function, which is often compromised due to dryness. Pharmacological management includes the use of topical corticosteroids as first-line therapy during acute flares. The choice of corticosteroid strength should be guided by the age of the child, the severity of the lesions, and the area of application. For example, low-potency steroids e.g. hydrocortisone are preferred for facial and intertriginous areas, while medium to high-potency steroids e.g. triamcinolone can be used on thicker skin areas. If the condition does not improve, calcineurin inhibitors such as tacrolimus or pimecrolimus can be utilized, particularly for sensitive areas due to their low risk of skin atrophy compared to corticosteroids. The rationale behind these choices lies in the understanding that atopic dermatitis is characterized by a defect in the skin barrier and an immune dysregulation that leads to inflammation. By restoring the skin barrier and reducing inflammation, symptoms can be managed effectively, minimizing flares and improving the quality of life. A pediatric patient presents with a maculopapular rash, fever, and conjunctivitis. The clinician suspects a viral etiology. What are the distinguishing features of common childhood viral exanthems such as measles, rubella, and roseola? Discuss the management and potential complications associated with these infections. Answer: measles, rubeola typically presents with a prodrome of high fever, cough, coryza, and conjunctivitis, followed by the onset of a characteristic maculopapular rash that starts at the hairline and spreads downwards. Koplik spots, which are small white lesions on the buccal mucosa, are pathognomonic. Rubella, on the other hand, presents with a mild fever and a rash that often starts on the face and spreads rapidly. Unlike measles, rubella is less severe and typically does not involve conjunctivitis or Koplik spots. Roseola exanthem subacem is characterized by a high fever for 3-5 days followed by a sudden appearance of a rash as the fever resolves. The rash is typically rose-colored and starts on the trunk before spreading to the extremities. Management of these viral exanthems primarily involves supportive care, including hydration, antipyretics for fever and rest. Complications can include encephalitis, pneumonia, and secondary bacterial infections in the case of measles, a congenital rubella syndrome in cases of maternal infection during pregnancy, and febrile seizures in roseola. Vaccination remains the cornerstone of prevention for measles and rubella. Mr. Thompson brings his 1-year-old daughter to the clinic due to a persistent diaper rash that has not improved despite using over-the-counter ointments. The rash appears red and irritated with some shiny patches and small pustules around the edges. What steps should Mr. Thompson take to manage his daughter's condition effectively? Outline the differential diagnosis and appropriate treatment strategies. Answer: Mr. Thompson's daughter likely has a case of irritant contact dermatitis or candidiasis, common in infants. The shiny patches and pustules suggest a possible secondary yeast infection. Differential diagnosis: irritant contact dermatitis. This is the most common cause of diaper dermatitis and is characterized by erythema and irritation due to prolonged exposure to moisture and friction. Candidiasis: this occurs when the skin becomes infected with candida, typically presenting as bright red patches with defined edges, and often includes pustules or satellite lesions. Bacterial superinfection: although less common, Staphylococcus or Streptococcus can lead to impetigo-like presentations. Management steps. Hygiene measures: Mr. Thompson should ensure regular diaper changes and gentle cleaning with water and a soft cloth. Air exposure should be encouraged by allowing the child to be diaper-free when possible. Barrier creams: application of zinc oxide or petrolatum-based barrier creams can protect the skin from moisture and irritants. Antifungal treatment: if candidiasis is suspected, topical antifungal agents e.g. clotrimazole or metronidazole should be applied. Consultation: if the rash persists despite these measures, Mr. Thompson should return for further evaluation and potentially consider prescription strength treatment or a referral to a dermatologist. Describe the clinical presentation of seborrheic dermatitis in infants and adolescents and outline the treatment options for each age group. Discuss the role of systemic therapies in severe cases. Answer: seborrheic dermatitis in infants, commonly referred to as cradle cap, presents as greasy yellowish scales and crusts on the scalp, often accompanied by redness. In adolescence, seborrheic dermatitis can affect the scalp, face, especially the nasolabial folds and upper trunk, presenting as erythematous patches with greasy scales. Treatment options: infants, non-pharmacological, regular washing with mild baby shampoo and gentle brushing can help loosen and remove scales. Topical treatments: if necessary, the use of non-medicated oils or low-potency topical corticosteroids can be effective for inflammation. Adolescents, medicated shampoos. Treatment often involves antifungal shampoos containing ketoconazole or selenium sulfide. Topical corticosteroids. For inflamed areas, low to mid-potency corticosteroids can be used sparingly. Systemic therapy. In severe cases that do not respond to topical treatments, systemic therapies like oral antifungals, e.g. fluconazole, may be considered, particularly if the patient has significant seborrheic dermatitis affecting quality of life. The role of systemic therapy should be carefully considered, taking into account the potential side effects and the patient's overall health status. What are the distinguishing features of gothate and plaque psoriasis in pediatric patients, and how do their treatment approaches differ? Include in your answer the importance of identifying triggers in the management of these conditions. Answer: gothate psoriasis is often triggered by infections, particularly streptococcal pharyngitis, and presents as numerous small drop-like lesions primarily on the trunk and extremities. In contrast, plaque psoriasis is characterized by well-defined erythematous plaques covered with silvery scales, commonly located on the elbows, knees, and scalp. Treatment approaches: gothate psoriasis. Management focuses on treating the underlying streptococcal infection with antibiotics, if present. Topical treatments include high-potency corticosteroids and vitamin D analogs. Phototherapy may also be beneficial in cases that are widespread or persistent. Plaque psoriasis. Treatment often starts with topical therapies such as corticosteroids and vitamin D derivatives. Severe cases may require systemic treatments including methotrexate or biologics. Identifying and managing triggers such as infections, stress, and skin trauma is critical in both conditions to prevent flares and improve long-term outcomes. Discuss the psychosocial implications of chronic skin conditions in pediatric patients. What strategies can healthcare providers implement to support affected children and their families? Answer: chronic skin conditions such as atopic dermatitis and psoriasis can significantly affect a child's quality of life, leading to issues such as social withdrawal, anxiety, and low self-esteem. The visible nature of these conditions can result in bullying or stigma, further exacerbating emotional distress. Support strategies: counseling, referral to mental health professionals can provide children with coping strategies and a safe space to express their feelings. Education. Educating both the child and family about the condition can reduce anxiety and empower them to manage it effectively. Support groups. Encouraging participation in support groups can help children connect with peers facing similar challenges, reducing feelings of isolation. Family involvement. Engaging family members in the treatment plan can improve adherence to management strategies and foster a supportive home environment. By addressing the psychosocial aspects, healthcare providers can enhance overall treatment outcomes and quality of life for pediatric patients with chronic skin conditions. A 4-year-old child presents with a large congenital nevus on the back. Discuss the potential risks associated with congenital nevi, particularly concerning melanoma development. What guidelines should be followed for surveillance and management? Answer: large congenital nevi carry an increased risk of melanoma, particularly when they exceed 20 centimeters in diameter, and they should be monitored closely. The risk of malignant transformation is approximately 5.10% for giant congenital nevi. Surveillance guidelines. Regular dermatologic evaluations. The child should undergo regular skin examinations by a dermatologist, typically every 1 to 2 months, to monitor for changes in the nevus, such as changes in color, size, or the appearance of symptoms like itching or bleeding. Education on self-examination. Parents should be educated on how to perform regular skin checks at home and when to seek medical advice if there are any concerning changes. Surgical consideration. Depending on the size and location, surgical excision may be considered, especially if there are changes in the nevus that raise suspicion for malignancy. In conclusion, a careful and proactive approach to managing congenital nevi is essential for early detection and intervention in cases of potential melanoma. A child presents with an itchy rash on the hands after using a new hand soap. Discuss the differential diagnosis for contact dermatitis in pediatric patients, including irritant and allergic types. What patch testing considerations are relevant in these cases? Answer: contact dermatitis can be classified into 2 main types: irritant contact dermatitis and allergic contact dermatitis. Irritant contact dermatitis This occurs due to direct damage to the skin barrier by substances such as soaps, detergents, or chemicals. It usually presents as localized erythema, dryness, and scaling. Allergic contact dermatitis. This occurs due to an immune-mediated response to allergens such as nickel fragrances or certain preservatives. It typically presents as a pruritic, erythematous rash that may have vesicles or crusting. Patch testing considerations. Patch testing is essential for identifying specific allergens in cases of suspected allergic contact dermatitis. However, it is generally not recommended in children under 2 years unless there are compelling reasons due to their skin's increased reactivity. When conducting patch tests, it is important to use age-appropriate allergens, and careful interpretation of results should consider common pediatric allergens. A 15-year-old male presents with facial acne characterized by comedones, papules, and pustules. Discuss the different types of acne, their pathophysiology, and the initial treatment strategies for this patient. Answer: pediatric acne can be classified into several types, including comedonal acne, characterized by open, blackheads and closed, whiteheads, comedones, resulting from follicular obstruction due to hyperkeratinization; inflammatory acne, presence with papules and pustules, resulting from Propionibacterium acnes colonization and subsequent inflammatory response; nodular cystic acne, severe form characterized by large, painful cysts and nodules leading to scarring. Pathophysiology: the development of acne involves increased sebum production, follicular hyperkeratinization, acnes proliferation, and inflammation. Initial treatment strategies: topical retinoids. First line for all types, aiding in normalizing keratinization. Benzoyl peroxide helps reduce acnes and has anti-inflammatory properties. Topical antibiotics for inflammatory lesions, although systemic antibiotics may be necessary in moderate to severe cases. A 10-year-old child presents with impetigo on the face. Discuss the clinical presentation of impetigo, its common pathogens, and the appropriate treatment options, including considerations for school attendance and contagion. Answer: impetigo typically presents as honey-colored crusted lesions, often on the face, around the nose and mouth, or on exposed areas of the body. It can arise from two primary pathogens: Staphylococcus aureus, including MRSA, and Streptococcus pyogenes. Treatment options: topical antibiotics. Mupirocin is commonly used for localized infections. Systemic antibiotics for more extensive cases or when topical treatment fails. Oral antibiotics such as cefalexin or clindamycin may be necessary, particularly if MRSA is suspected. Contagion and school attendance. Children with impetigo should stay home until 24 hours after starting appropriate antibiotic therapy to minimize the risk of transmission to classmates. Good hygiene practices, including hand washing and avoiding sharing personal items, are crucial in preventing spread. Describe the anatomy of the epidermis and its role in skin function. How does the structure of the epidermis contribute to its barrier function? Answer: the epidermis is the outermost layer of the skin, composed primarily of keratinocytes, which originate from the basal layer and undergo a process of differentiation as they migrate upwards. This layer is stratified into several sublayers: the stratum corneum, stratum granulosum, stratum spinosum, and stratum basale. Stratum corneum, composed of dead keratinized cells that provide a physical barrier to environmental insults and minimize water loss. Stratum granulosum contains keratinocytes undergoing keratinization, which contributes to the barrier properties by producing lipids that seal the intercellular spaces. Stratum spinosum contains Langerhans cells, which play a role in immune defense and provide structural integrity. Stratum basale, the base layer where active cell division occurs, replenishing the upper layers. The integrity of the epidermal barrier is crucial for preventing transepidermal water loss, and protecting against pathogens. Disruptions in this barrier can lead to conditions such as eczema and psoriasis, highlighting the importance of proper keratinocyte function and lipid production. Explain the process of melanogenesis and the factors that influence melanin production in the skin. What role do genetic and environmental factors play in this process? Answer: melanogenesis is the biochemical process through which melanin is produced by melanocytes located primarily in the basal layer of the epidermis. The process involves several steps. Tyrosine conversion. The amino acid tyrosine is converted into DOPA dihydroxyphenylalanine by the enzyme tyrosinase, which is a critical step in melanin synthesis, formation of eumelanin and pheomelanin. Depending on the activity of subsequent enzymes, DOPA is further processed into either eumelanin, brown-black pigment, or pheomelanin, yellow pigment. Factors influencing melanin production include genetics. Variations in the MCRD can lead to differences in skin pigmentation and susceptibility to UV damage. Environmental. UV radiation stimulates melanin production as a protective response against skin damage. Hormonal changes, such as those occurring during pregnancy, e.g., melasma, can also influence pigmentation. Discuss the role of Langerhans cells in the skin's immune response. How do they interact with other immune cells to mount an adaptive immune response? Answer. Langerhans cells, or CS, are specialized dendritic cells located in the stropum spinosum of the epidermis. They play a critical role in the skin's immune defense through several key functions. Antigen presentation. LCS capture and process antigens from pathogens, then migrate to regional lymph nodes. They present these antigens to naive T cells, leading to T cell activation. Cytokine secretion. Upon activation, LCS release cytokines such as IL-12 and IL-6, which promote T cell differentiation into specific subsets, such as Th cells that are crucial for orchestrating the immune response, migration, and memory formation. LCS can also influence the differentiation of memory T cells, which are essential for a quicker response upon re-exposure to the same antigen. Through these interactions, Langerhans cells bridge the innate and adaptive immune systems, underscoring their importance in the skin's overall immune function. Mr. Smith is a 45-year-old patient presenting with a new pigmented lesion on his left forearm. He reports that it has been growing steadily over the past 6 months and is asymptomatic. Considering his family history of skin cancer and previous sunburns, what steps should Mr. Smith take for further evaluation and management of this lesion? Answer. Given Mr. Smith's history and presentation, it is critical to assess the lesion further for potential malignancy. The following steps should be recommended. Comprehensive dermatological evaluation. Mr. Smith should see a dermatologist for a thorough skin examination, including the use of dermatoscopy to assess the lesion's characteristics such as color, asymmetry, border irregularity, and diameter. The A, B, C, D criteria for melanoma. Biopsy. If the lesion appears suspicious, an excisional biopsy should be performed to obtain histological confirmation of the diagnosis. This is crucial for distinguishing between benign and malignant lesions, particularly melanoma. Sun protection education. Given his history of sunburns, Mr. Smith should receive counseling on sun protection strategies, including the use of broad-spectrum sunscreen protective clothing and avoiding peak sun exposure times. Follow-up. Depending on the biopsy results, appropriate follow-up and management plans should be established. If malignant, referral to an oncologist may be necessary for further treatment options, including possible surgical intervention or immunotherapy. Explain the significance of barrier function in the context of skin hydration and the mechanisms by which the skin maintains its moisture. What role do ceramides and natural moisturizing factors, NMF, play in this process? Answer. The skin's barrier function is vital for maintaining hydration and preventing transepidermal water loss. Tool. Several mechanisms contribute to this barrier function. Stratum corneum structure. The stratum corneum acts as the primary barrier, composed of corneocytes, dead keratinocytes embedded in a lipid matrix rich in ceramides, cholesterol, and fatty acids. This structure helps to prevent water loss while allowing for some permeability. Ceramides. These sphingolipids are crucial components of the lipid bilayer within the stratum corneum. They help to retain moisture and improve the barrier function by providing structural integrity and reducing TWL. Ceramides can also play a role in signaling pathways related to skin repair and inflammation. Natural moisturizing factors, NMF. NMFs are water-soluble compounds primarily made up of amino acids, urea, and lactate, which are present in the corneocytes. They attract and bind water, maintaining hydration levels in the skin. By retaining moisture, NMFs enhance the flexibility and softness of the skin, contributing to its overall health. Together, ceramides and NMFs work synergistically to ensure the skin remains hydrated, preventing conditions such as dryness and eczema. Discuss the impact of genetic mutations in keratinocytes on the development of epidermolysis bullosa (EB). How do these mutations affect the structural integrity of the skin? Answer. Epidermolysis bullosa (EB) is a group of inherited disorders characterized by fragile skin that blisters easily in response to minor trauma. The underlying cause of EB lies in mutations in genes encoding structural proteins that maintain the integrity of the skin's epidermal layers. Types of mutations. Most commonly, mutations occur in genes encoding keratins, collagen, or integrins, which are essential for the structural integrity of the skin. For instance, mutations in KRT-ART genes lead to a form of E, B called junctional E, B which affects the basal layer keratinocytes. Structural impact. These mutations disrupt the normal assembly and function of the cytoskeleton, within keratinocytes, leading to decreased tensile strength and compromised adhesion to the underlying dermis. As a result, the epidermis is more susceptible to mechanical stress, causing separation and blister formation. Clinical manifestations. The clinical consequences of these mutations can vary from localized blistering to widespread skin fragility depending on the specific mutation and its effect on skin structure. The management of EB often involves protective measures, wound care, and in some cases, surgical interventions to alleviate symptoms and improve quality of life. Outline the mechanisms by which cytokines and chemokines contribute to skin inflammation. What are the potential implications for dermatological diseases? Answer: cytokines and chemokines are signaling molecules that play pivotal roles in the regulation of immune responses in the skin, particularly during inflammatory processes. Their mechanisms include cytokine production. Cytokines such as IL-1, IL-6, and TNF are produced by keratinocytes, Langerhans cells, and other immune cells in response to injury or infection. These cytokines amplify the inflammatory response by attracting additional immune cells to the site of inflammation. Chemotaxis. Chemokines, a subset of cytokines, specifically mediate the recruitment of immune cells, e.g. neutrophils, macrophages, T cells, to areas of inflammation. For example, IL-8 is a potent chemokine that attracts neutrophils to sites of infection or injury. Pathways of inflammation. The signaling pathways activated by these cytokines can lead to increased vascular permeability, promoting edema and redness in the inflamed skin. Implications for disease. Overexpression of pro-inflammatory cytokines can contribute to chronic inflammatory skin diseases. Understanding these pathways offers potential therapeutic targets. For instance, biologics that inhibit specific cytokines have shown promise in managing diseases such as psoriasis and atopic dermatitis. Analyze the impact of epigenetic modifications on skin aging. How do these modifications influence gene expression related to dermatological health? Answer: epigenetic modifications refer to heritable changes in gene expression that do not involve alterations in the DNA sequence. These modifications, including DNA methylation, histone modification, and non-coding RNA expression, significantly influence skin aging and dermatological health. DNA methylation. Hypermethylation of genes involved in cellular repair and antioxidant defense mechanisms can lead to reduced expression of these protective genes, contributing to skin aging and increased susceptibility to environmental damage. Histone modification. Changes in histone acetylation and methylation can affect chromatin structure, influencing the accessibility of transcription factors to DNA. For example, decreased histone acetylation is often associated with the repression of genes critical for skin cell proliferation and repair, leading to slower wound healing and a thinner epidermis. Impact on cellular function. These epigenetic changes can result in altered keratinocyte function, reduced collagen synthesis, and diminished barrier function, all of which are characteristic of aged skin. Furthermore, they can enhance inflammatory responses, leading to a greater incidence of skin disorders such as dermatitis and skin cancers. Potential for reversal. Understanding the epigenetic landscape of aging skin presents opportunities for therapeutic interventions, such as the use of epigenetic modulators that could potentially reverse some of the effects of aging at the cellular level. By targeting these epigenetic modifications, there may be new strategies for promoting healthier skin aging and mitigating the effects of environmental stresses. Evaluate the clinical significance of molecular markers in skin cancer diagnosis and prognosis. What role do they play in the management of patients with cutaneous malignancies? Answer: molecular markers play a critical role in the diagnosis, prognosis, and management of skin cancers, particularly melanoma and non-melanoma skin cancers. Their clinical significance includes diagnostic utility. Certain molecular markers, such as BRAF mutations, can help confirm a diagnosis of melanoma, especially in ambiguous cases. Testing for these mutations aids in stratifying patients for targeted therapies. Prognostic indicators. The presence of specific markers, such as PINKA and Ki67, can provide information about the aggressiveness of the tumor and potential outcomes. For instance, high Ki67 expression is associated with increased tumor proliferation and worse prognosis. Therapeutic targets. Targeted therapies, such as BRAF inhibitors, e.g. vemurafenib, are designed to exploit specific mutations in the tumor's DNA. Identifying these mutations allows for personalized treatment plans, enhancing the effectiveness of therapy. Monitoring recurrence. Molecular markers can also be used to monitor for recurrence post-treatment. Liquid biopsies analyzing circulating tumor DNA can detect residual disease and guide subsequent treatment decisions. Explain the principles behind cutaneous immunology. focusing on the role of T cells in skin health and disease. How do T cells mediate both protective and pathological responses? Answer: cutaneous immunology encompasses the complex interactions between the immune system and the skin, with T cells playing a central role in maintaining skin health and responding to disease. Types of T cells. The skin hosts various T cell subsets, including CD helper T cells, CD autotoxic T cells, and regulatory T cells, TREGs. Each subset has distinct functions in immune responses, protective responses, upon encountering antigens e.g. from pathogens. Skin-resident memory T cells can quickly mount an immune response. CD T cells help activate B cells to produce antibodies, while CD T cells directly eliminate infected or malignant cells. Pathological responses. In contrast, dysregulation of T cell responses can lead to pathological conditions. For example, excessive activation of Th cells is implicated in allergic reactions and atopic dermatitis, while Th cells may contribute to inflammatory conditions like psoriasis. Regulatory mechanisms. TREGs play a crucial role in maintaining skin homeostasis by suppressing excessive immune responses and preventing autoimmunity. An imbalance between effector T cells and TREGs can lead to chronic inflammation and skin disorders. Understanding the dual roles of T cells in skin health and disease emphasizes the importance of balanced immune responses, with implications for developing targeted therapies that modulate T cell activity in various dermatological conditions. Explain the histological features that differentiate between spongiotic dermatitis and psoriasiform dermatitis. What are the key microscopic changes observed in each condition? Answer: spongiotic dermatitis, commonly associated with eczema, displays key histological features that include pronounced intercellular edema, spongiosis, within the epidermis. This edema results in a separation of keratinocytes, which can lead to the formation of vesicles or bulli. The inflammatory infiltrate typically consists of lymphocytes and eosinophils, often localized to the papillary dermis, with occasional crust formation at the surface due to exudation. In contrast, psoriasiform dermatitis, as seen in psoriasis, is characterized by significant epidermal hyperplasia, acanthosis, and hyperkeratosis. The stropon corneum is thickened and elongated. Tear ridges are commonly observed. There is a marked inflammatory infiltrate comprising neutrophils, which can form microabscesses known as Monro microabscesses within the stropon corneum. Histologically, the distinction between these two conditions is critical for diagnosis and therapeutic decisions, as treatment for spongiotic dermatitis often focuses on reducing inflammation and managing the immune response, while psoriasis may require agents that specifically target hyperproliferation and scaling. Describe the histological findings associated with drug eruptions and contact dermatitis. How do these conditions differ in terms of their inflammatory response? Answer: histological evaluation of drug eruptions typically reveals a mixed infiltrate of lymphocytes and eosinophils in the papillary dermis, with interface dermatitis often noted, characterized by liquefactive degeneration of the basal cell layer of the epidermis. The appearance of eosinophils indicates an allergic response, which can vary depending on the drug and the individual's sensitivity. Additionally, drug eruptions may present with features resembling either spongiotic dermatitis or lichenoid tissue reaction patterns, complicating diagnosis. In contrast, contact dermatitis, particularly allergic contact dermatitis, shows significant spongiosis and a perivascular lymphocytic infiltrate within the dermis. The inflammatory response in contact dermatitis is more localized and often directly correlated with exposure to the offending allergen. The presence of Langerhans cells may also be prominent in allergic contact dermatitis, facilitating the antigen presentation that triggers the hypersensitivity response. Understanding these histological features allows clinicians to tailor their treatment strategies, emphasizing avoidance of triggers in contact dermatitis, while drug eruptions may necessitate immediate cessation of the offending medication. Mr. Johnson is a 45-year-old man presenting with a rapidly enlarging lesion on his back. Histological examination reveals nests of atypical melanocytes with a high mitotic index. What steps should Mr. Johnson take next in terms of management, and what staging criteria should be considered in this situation? Answer: given the findings of atypical melanocytes with a high mitotic index in Mr. Johnson's lesion, he should undergo a complete excisional biopsy to confirm the diagnosis of melanoma. This initial procedure is critical not only for obtaining a definitive diagnosis, but also for determining the depth of invasion and potential metastases. Upon confirmation of melanoma, staging is paramount and follows the American Joint Committee on Cancer AJC criteria. Key aspects include assessing the Breslow thickness, which measures the depth of the melanoma from the granular layer of the epidermis to the deepest point of tumor invasion. Ulceration status of the tumor should also be noted, as it significantly impacts prognosis. Next, the involvement of regional lymph nodes must be evaluated. This can involve sentinel lymph node biopsy to assess for metastases. Distant metastases is assessed through imaging studies if indicated. Understanding the stage of melanoma will guide Mr. Johnson's treatment plan, which may include surgical options, immunotherapy, or targeted therapy based on the stage and other prognostic factors. This thorough management approach ensures a comprehensive strategy for combating the disease. Identify the key microscopic features of granulomatous inflammation as seen in infectious conditions such as tuberculosis and leprosy. What are the implications of these findings for patient management? Answer: granulomatous inflammation, a chronic inflammatory response, is characterized by the formation of granulomas, aggregates of activated macrophages that often transform into epithelioid cells. In the context of tuberculosis, granulomas exhibit caseating necrosis at the center, surrounded by a mixture of macrophages, lymphocytes, and multinucleated giant cells. The presence of caseation is significant as it indicates a specific immune response to the Mycobacterium tuberculosis organism. In contrast, leprosy caused by Mycobacterium leprae often presents with non-caseating granulomas. These granulomas are typically composed of foamy macrophages, particularly in lepromatous leprosy, and may show a more pronounced lymphocytic infiltrate. The identification of granulomatous inflammation informs patient management significantly. In cases of tuberculosis, a positive histological finding necessitates prompt initiation of antitubercular therapy to prevent disease progression and transmission. For leprosy, specific multi-drug therapy (MDT) is essential. Recognizing these histological features not only assists in confirming the diagnosis but also guides the appropriate therapeutic strategies to effectively manage these chronic infections. Explain the differences in histological presentation between basal cell carcinoma (BCC) and squamous cell carcinoma (SCC). How do these differences influence the approach to treatment? Answer: basal cell carcinoma (BCC) typically presents histologically with nests of basaloid cells in the dermis, often exhibiting peripheral palisading of nuclei. This feature is characteristic of BCC and highlights its less aggressive nature compared to other skin cancers. BCC is generally well circumscribed, has a low mitotic index, and is rarely metastatic. In contrast, squamous cell carcinoma (SCC) demonstrates atypical keratinocytes invading the dermis with a propensity for keratinization differentiation. Histologically, SCC shows higher mitotic activity, nuclear polymorphism, and an irregular infiltrative pattern. The presence of necrosis within the tumor is often observed, and SCC has a greater tendency to metastasize, particularly when deeper layers of the skin are invaded. These differences in histological presentation directly influence treatment approaches. For BCC, local excision or Mohs surgery suffices due to its low metastatic potential. Conversely, SCC may require more aggressive surgical measures, sentinel lymph node biopsy, and possibly adjuvant therapies, including radiation or chemotherapy, especially in high-risk cases or metastatic disease. Identify the implications of identifying viral inclusions in a tissue sample. What specific viral infections are commonly associated with these findings, and how should these cases be managed? Answer: the identification of viral inclusions in tissue samples is a crucial diagnostic tool in dermatopathology, as it allows for the rapid identification of certain viral infections. Common examples include herpes simplex virus (HSV), which presents with multinucleated giant cells and Cowdery-type inclusions in epidermal cells of varicella zoster virus (VV), also display similar histological features, facilitating diagnosis of chickenpox or shingles. Cytomegalovirus (CMV) infections are characterized by large cells containing intranuclear inclusions and owl-like appearances typically seen in immunocompromised patients. The management of these viral infections often involves antiviral therapy tailored to the specific virus. For HSV and VZV, medications such as acyclovir are commonly employed to reduce viral replication and alleviate symptoms. In the case of CMV, particularly in immunosuppressed individuals, ganciclovir or foscarnet may be necessary to control the infection. Recognizing these viral inclusions not only aids in diagnosis but also influences management strategies. Prompt antiviral treatment is essential to mitigate complications, especially in high-risk patients, ensuring a targeted and effective therapeutic approach. Mrs. Smith, a 60-year-old woman, presents with a non-healing ulcer on her lower leg. A biopsy reveals keratinizing squamous cell carcinoma. What are the potential risk factors for the development of this type of cancer, and what comprehensive treatment options should be considered? Answer: in Mrs. Smith's case, several risk factors may have contributed to the development of keratinizing squamous cell carcinoma (SCC). These include chronic sun exposure, particularly in fair-skinned individuals, leading to cumulative UV damage over time. Other risk factors encompass immunosuppression, e.g., in transplant recipients or individuals with HIV/AIDS, chronic wounds or scars that can undergo malignant transformation, and exposure to carcinogenic substances such as arsenic or coal tar. The comprehensive treatment options for SCC should begin with a thorough evaluation of the tumor's characteristics, including size, depth of invasion, and location. Treatment generally includes surgical excision, which may be sufficient for localized lesions. Mohs micrographic surgery is often preferred for facial or high-risk locations due to its ability to ensure complete tumor removal while preserving surrounding healthy tissue. In cases where SCC is more advanced or metastasized, additional options may include radiation therapy for non-surgical candidates or those refusing surgery. Furthermore, systemic treatments, such as chemotherapy or targeted therapy, may be indicated in advanced cases. What are the main characteristics of melanocytic nevi? How can these features assist in differentiating benign nevi from malignant melanoma? Answer: melanocytic nevi, or moles, exhibit distinct characteristics that aid in differentiating them from malignant melanoma. Benign nevi typically present as well-circumscribed, uniformly colored lesions that can range from tan to brown. Histologically, they are composed of nests of melanocytes at the dermal-epidermal junction and within the dermis, demonstrating a symmetrical pattern without atypia or significant mitotic activity. Conversely, malignant melanoma presents with irregular borders, asymmetry, and variegated colors. Histologically, melanoma is characterized by atypical melanocytes that exhibit a high degree of pleomorphism, abnormal mitotic figures, and invasion into the dermis with a disorganized architecture. Clinical assessment tools such as the ABCD criteria, asymmetry, border irregularity, color variation, diameter 6 mm, and evolving nature can further assist clinicians in evaluating pigmented lesions. Understanding these characteristics is crucial for timely intervention. A diagnosis of melanoma often necessitates aggressive management strategies, including surgical excision and potentially systemic therapies, whereas benign nevi may only require monitoring for changes over time. Discuss the histological features of lupus erythematosus and their significance in distinguishing between systemic lupus erythematosus, SLE, and cutaneous lupus erythematosus, CLE. Answer: lupus erythematosus is characterized by distinct histological features that vary between systemic lupus erythematosus, SLE, and cutaneous lupus erythematosus, CLE. In CLE, which can present as discoid lupus or subacute cutaneous lupus, histology typically shows a perivascular lymphocytic infiltrate interface dermatitis with liquefactive degeneration of the basal cell layer and the presence of a follicular plugging with keratinous debris. The presence of mucin deposits in the upper dermis is also noted, contributing to the characteristic violaceous hue of lesional skin. In contrast, SLE may exhibit similar skin findings but also has systemic implications, with additional histological findings such as vascular damage and deposition of immune complexes. SLE is often associated with changes in the dermis, including vasculitis, and is more likely to present with systemic symptoms like arthritis and renal involvement. These histological distinctions are vital for diagnosis and management. Recognizing the cutaneous manifestations of lupus can aid in early intervention, while identifying systemic involvement in SLE can necessitate a more comprehensive treatment strategy, including immunosuppressive therapy. Describe the role of dermoscopy in the evaluation of pigmented lesions. What specific features does dermoscopy reveal that aid in distinguishing between benign and malignant lesions? Answer: dermoscopy is an essential non-invasive diagnostic tool that enhances the visualization of pigmented lesions, providing crucial information for differentiating benign nevi from malignant melanoma. Key features that dermoscopy reveals include asymmetry in structure and color, where benign lesions tend to display symmetry, while malignant lesions often show irregularities. Border irregularity is another important dermoscopic characteristic. In malignant melanomas typically exhibit jagged or poorly defined edges contrasting with the smooth borders of benign nevi. Additionally, color variegation is significant, as benign lesions usually present with a uniform color, while malignant ones may display multiple shades, including brown, black, red, or white. The presence of specific dermoscopic structures further assists in diagnosis. For example, the detection of atypical vascular patterns, such as dotted or linear vessels, alongside the strawberry pattern seen in some melanomas, can signal malignancy. Overall, dermoscopy significantly improves diagnostic accuracy, allowing for earlier intervention in cases of malignant melanoma and other skin cancers.